Good evening, welcome to the webinar and greetings from Perth. Tonight we are extremely fortunate to be joined by a world-leading clinician, Professor Lisa Heitz Mayfield, and she will be providing what I'm sure will be an extremely entertaining presentation for you on the topic of peri-implantitis, decision-making in clinical practice. I would like to start by telling you a little bit more about the speaker this evening. Professor Lisa Heitz Mayfield, an Adelaide graduate, obtained a Master's in Periodontology in 1996 from Lund University, Sweden, and a PhD in 1998 on periodontal and peri-implant regeneration. She received Brånemark Osseointegration, an ITI scholarship, and the Andre Schroeder Research Prize in Implant Dentistry, and became head of the Oral Microbiology Research Laboratory at the University of Bern. She has more than 45 publications in peer-reviewed international journals, and is the author of several textbooks. She is adjunct professor at the International Research Collaborative, the University of Western Australia, associate professor at the University of Sydney, and at the University of Hong Kong. She is chairman of the International Team for Implantology Research Committee and member of the ITI Board of Directors. She is editor-in-chief of Clinical Oral Implants Research. Before handing over to Professor Heitz Mayfield, I'd just like to give you a little background about today's webinar, which is the first in a series of 6 webinars entitled the Geistlich World Webinar Tour 2017, and which is actually part of the Geistlich Key to Success. What is the key to success? Well, your trust made us the worldwide #1 reference, with more than 10 million patients treated with Geistlich BioOss, Geistlich BioGuide, and Geistlich Mucograft, and collaborations with more than 100 universities worldwide. We would like to share the knowledge and the treatment concept about products that will lead to success. The idea of sharing knowledge is at the heart of the webinars. The webinar is of course live and interactive, and we encourage you all to ask questions to the professor throughout the presentation. We will collate all the questions and have a Q&A session at the end of the webinar. I will draw your attention to the dialog box at the bottom of your screen, which is where you are able to submit your questions during the presentation. After the webinar, you will find it recorded on our homepage. And finally, I would like to make one more point and mention the upcoming webinar, and hope that you will join us again on the 3rd of May at 7 p.m. GMT, that's UK time, where Dr. Michael Norton will address the topic of assessment and planning before sinus lift. So once again, thank you for joining us for this webinar this evening. And I will now hand over to our speaker, Professor Heitz Mayfield.
Good evening, and welcome to this webinar on peri-implantitis, clinical decision making. I'd like to start this webinar by making very clear to all listening the definition of peri-implantitis. This is fundamental that we all understand what we're talking about if we're going to make the right clinical decisions. So in the European Workshop on Periodontology in 1994, it was clearly defined as inflammation of the peri-implant mucosa with loss of supporting bone. And in these clinical images you see on the screen and radiographs, it's very obvious that there are signs of clinical inflammation, bleeding and pus on probing, and the radiographs both show, depicted by the red arrows, that there is considerable or advanced loss of bone in these 2 cases. Now, in contrast, we have the definition of peri-implant mucositis. And here this was defined as inflammation of the peri-implant mucosa without loss of supporting bone. And in these clinical images and radiographs, again, you can see signs of clinical inflammation, bleeding, some redness of the tissues, but the radiographs show that the bone levels are where one would expect them to be. In this case, we're looking at 2 tissue-level implants with the bone levels at the border of the rough to smooth interface, and that is where we would expect the bone to be. So when making a clinical diagnosis, it is helpful to have baseline radiographs and see if there has indeed been loss of supporting bone. Now, the prevalence of peri-implantitis is also something I'd like to address initially before we look at clinical decision making. And there has been a lot of controversy in the literature about the prevalence of peri-implantitis. And probably one of the main reasons that we've had this controversy is that people use different thresholds for both bone loss and probing depths when they define peri-implantitis. So if we look to the literature, we see a wide range of definitions used, and this has resulted in many different descriptions of the prevalence of disease. Now, in this study you see illustrated on this slide, this was done by Koldsland and co-workers in 2010. They published this study from the University of Oslo in Norway. They had 164 subjects with implants that had been in function for an average of around 8 years. And they examined these individuals and they categorized them into both on a subject level and an implant level as to whether there was inflammation with any detectable bone loss, and they had 47% of subjects. When they changed their definition to the presence of bleeding on probing and probing depths of greater than 4 millimeters with a bone loss of more than 2 millimeters, now they have a percentage of 20% of subjects and 11% of implants. And of course, if we change the threshold again, we'll get a different figure. So if we accept bone loss of more than 3 millimeters, now we only have 11% of subjects. And if you look at the radiographs in the bottom of the slide, you can see one radiograph taken at baseline, and now several years later you can clearly see signs of bone loss. But depending on which definition we might use, we could have 1, 2, or possibly all of the implants in this subject with peri-implantitis. So herein lies the problem, and this is why we see so much variation in the literature. Now recently there have been a number of systematic reviews which have looked at this issue of prevalence. The first I'd like to show you is the one published in 2012 by Mombelli and co-workers. They were able to analyze 23 different studies which had various definitions and thresholds, and they also acknowledged that there were differences in the study populations. And what they found is when they did a meta-analysis, they had, after 5 to 10 years of implant placement, a prevalence of 20% of patients with peri-implantitis. That means 1 in 5. And that was around 10% of the implants. Now, a more recent systematic review, published by Dirks and Tomasi in 2015, has showed similar figures. They included less studies, their inclusion criteria was more strict, but they had 22% of patients after around 10 years with the presence of peri-implantitis. And here you see the confidence interval, 14 to 30%. So from this we see that it clearly is a problem we need to address. In the next slide you see a graph which shows the number of implants sold worldwide from 2003 up to estimated values at 2023. And the blue line at the bottom of the graph shows the number of implants sold worldwide each year, which is around 10 to 12 million. Now, if we look at the red line, this is the cumulative number of implants that are sold across this time period. And you can see that we have more than 200 million implants which have been sold and used over this period of time. So in the year 2023, we are going to have many implants out there. And if we look at the prevalence data, and if we think of the prevalence of 10% of implants, then you can imagine the enormous number of implants that have been affected by peri-implantitis. So clearly we need to have good strategies, and we also need to have good preventive strategies and make sure we diagnose these problems early, because that is often a much easier way to manage them than if we wait too late. So peri-implantitis therapy is challenging. And for those of you who have treated these problems, you will agree with me that the results you see on this slide, where we have pre-treatment and 5-year results, we don't always see. It seems to be rather unpredictable, and it is certainly challenging. So here are 2 clinical cases that I've treated over the past 10 years where certainly there's been a very nice outcome, and if you look at the radiographs, it looks as if there's been good bone regeneration, and the clinical outcome at 5 years is also very successful. No bleeding, the tissues look healthy, and the probing depths are relatively shallow, so not greater than 5 millimeters. But the question is, what is the best treatment to apply in order to achieve these results? And that is a question that I'm going to address over the next 40 minutes. So when we think about clinical decision making and our treatment in the clinic every day that we are coming in, and we don't know what we're going to be referred, or whether they'll be our patients that come through the door with a problem, or perhaps somebody else's patient, but we still need to make some very important decisions. And the first after we have a diagnosis is, what type of non-surgical management might we choose? What type of decontamination method? And will we use antimicrobials or not? The next decision we need to make is whether or not we might need to do a surgical therapy. And here we have choices to make also. Will we do an open flap debridement or an access flap? Might we choose resective therapy or regenerative therapy? And if we choose this option, we need to decide which biomaterials we will use. We have other decisions to make. Sometimes the best decision might be implant removal. So I'll also discuss this. And if we do remove an implant, will we then do augmentation, considering the possibility of a new implant? Or will we in fact decide that it might be better to choose an alternate solution? Now, some of the clinical decisions also involve discussing with the patient what the possibility might be in terms of adverse outcomes. And I think this is a really important point. Recession of the soft tissue margin or possible recurrence of disease is something we should discuss with the patient right up front. And with all of these treatments I'm going to describe, we need to also consider the costs and the patient preference. So on this slide you see that the decision-making process is not easy, and I'm going to try and give you some clear guidelines as to how you should approach these decisions that you'll be making. Now, I'd like to show you the results of a systematic review that I did together with Andrea Mombelli. In 2014 it was published in iGomi, and this was done in preparation for the ITI Consensus Conference, which was held in Switzerland in 2013. Now, the aim of this particular review was to evaluate the success of treatment aimed at the resolution of peri-implantitis. And this particular review was a little different to some of the others that have been published, where they look specifically at bone level changes or probing depth reduction. Here we tried to look at the overall success of the treatment in terms of resolution of the disease. So that would mean reduction or resolution of bleeding, no deep pockets anymore, no progression of bone loss, and of course the implant should still be in place. So we looked into the literature where we looked at all types of studies, not just randomized controlled trials. And you can see in this table the 43 publications we found, some with non-surgical interventions, case series and comparative studies, and then others with surgical interventions, again, case series and comparative studies. Interestingly, we found no studies where they compared non-surgical therapy with surgical therapy. Now let me go on to show you what we looked for. Here we looked at a composite success criteria, which is now considered important to report in studies. So again, you see that the implant should be successfully there with no pus, the absence of deep pockets and bleeding, and no additional bone loss. Now I'd like to show you one of the tables from our review which illustrates the difference on the variety of different treatment approaches from the case series of surgical therapies. Now, I don't expect you to read everything on this slide, but to the left we see the authors, then the number of patients, the number of implants, relatively small numbers of patients in these studies. We see the implant type, the disease definition, and then we see in the next column the pre-treatment that the patients received. And this varied considerably. Some had non-surgical debridement, others there was nothing reported in terms of pre-treatment. Some had the use of lasers, some studies removed the prosthesis, and some only gave the patients oral hygiene instruction. So there was a huge range in the pre-treatment. We then look at the next column, we see the surface treatment that was applied to the implant. And this also varied dramatically, from the use of air powder abrasives to various chemicals and lasers and different types of curettes that were used to clean the surface. Furthermore, in these surgical therapies, there were many different antimicrobials used, different types of antibiotics ranging from tetracycline, metronidazole, amoxicillin, and clindamycin. And also, in these case series of surgical therapies, the majority of the materials used during the surgery were graft materials. So many of the studies, or most of the studies, employed some type of biomaterial or autogenous bone with or without a membrane. It might have been a resorbable membrane or even a non-resorbable, such as the EPTFE membrane. So you start to see the picture. The studies are very varied, and it is very difficult to combine these studies in a meta-analysis, and therefore in our paper, in our systematic review, we were unable to do this. But when we looked at the various studies, we found when we looked at the results of these individual studies, the clinical parameters improved in the majority of patients and the majority of implants. However, complete resolution according to this composite success criteria I've described was not usually achieved for all patients. So some patients had post-surgical complications, including membrane exposure and recurrent infection, and many patients also had soft tissue recession, particularly when they'd had a surgical treatment. So these were things we noted in the review. But when we looked at the papers, we could see where there were 12 months results. The list of papers you see on this slide had a range, but the majority of patients had successful outcomes. These in yellow at the top, these 3 papers were non-surgical treatment, and the remainder were surgical therapies, the majority of which were regenerative surgeries. We found also that some patients had recurrence of disease and also implant loss, and that was reported in these studies. What we did note when we looked carefully into the papers, the ones that had successful treatment outcomes tended to use the same types of steps within their protocol. And so then within the group at this consensus conference, which was titled, our group was titled Prevention and Management of Technical and Biological Complications, what we did was we tried to look at all of these papers and come up with the steps that they had used in order to give some clinical recommendations. And so if our goal is to resolve the infection and prevent recurrence of disease, the common steps that were applied in these studies were summarized in the 6-step protocol, which is aiming to have a successful outcome. And these steps are firstly the pre-treatment phase. Step 2 is the non-surgical debridement, then a reassessment done quite early, followed by, if there is not resolution of disease, a surgical treatment approach, and then importantly the immediate post-operative care and the supportive care. So within the group, based on the systematic review, we came up with some steps that can be followed in order to get the best outcome. And I'd like to now go through these steps carefully and give you some of the evidence based on the recommendations. So firstly, when you have a patient who obviously has a problem, you need to do a careful assessment and make the right diagnosis. Do you indeed have a peri-implantitis, or could it be a peri-implant mucositis? And of course, we mustn't forget that sometimes there are other conditions, mucosal conditions, which are unrelated to infection. So a careful assessment and diagnosis is important. We need, for example, to look and see if there are any prosthetic factors which may be contributing to the biological complication. And on this slide you can see at the top there is a clinical image where there are two draining sinuses, or fistula they're often called, at the lateral incisor implants. And this is often seen when there is loosening of the screws in a screw-retained prosthesis. So here that would need to be dealt with first before any other anti-infective treatment was applied. And to the right you see a crown which is clearly not seated correctly. This has been cemented, and when an X-ray is taken you can clearly see the problem and the reason why the infection is there. Now, other risk factors such as poor oral hygiene, smoking, and diabetes or uncontrolled diabetes have also been reported in the literature, and these need to be assessed carefully in order to try and reduce these risk factors before the treatment is started. So this pre-treatment phase is a very important one to determine exactly the problem. And you can see in the bottom series of clinical images that there is a patient with a full arch screw-retained prosthesis where the patient has a peri-implant infection and no possibility to perform good oral hygiene. So the first step here is to actually remove the prosthesis, adjust it, so that the patient can then access with an interdental brush. Let's move on now to the non-surgical debridement phase, step number 2. And here any calculus or biofilm removal supramucosally should be performed, and you may or may not choose to administer antimicrobials. There may be antiseptics such as chlorhexidine, systemic antimicrobials, or local delivery devices if they are available in your country. Now, with this non-surgical debridement phase, the main aim is to remove the visible calculus and biofilm supramucosally and submucosally as far as possible. But when there is a very deep probing depth, this can be very challenging, and it is frequent that you will need to go on and do surgery. But it really should be firstly addressed, this non-surgical debridement, rather than going straight to a surgical phase. And in this slide you see a little video of an air powder abrasive device being used. This is with, in this instance, erythritol powder. There are also studies showing with glycine powder where this is very effective in removing the biofilm submucosally. And this systematic review, published in 2015 by Frank Schwartz and his co-workers, showed in a meta-analysis that the use of an air polishing device may improve the efficacy of non-surgical treatment over control. And the control here was mechanical debridement with curettes alone, with or without local antiseptics, or in other studies they used the erbium yak laser. So this is a very effective way for non-surgical treatment of peri-implant disease. Here you see this little video again. And now we'll move on to the next slide, which is step number 3, the reassessment. And here an early reassessment should be done after the non-surgical phase, so within 1 to 2 months. If resolution of the disease is noted, as you see in this clinical image, the tissues are now looking healthy, there's some exposed titanium surface which the patient can keep clean, and they then go into a maintenance care phase or supportive peri-implant therapy. If, however, the resolution of the infection is not achieved, that's when we need to go to the next step of additional therapy, which is usually surgical therapy. Now, I'm going to show you 3 clinical cases now. The first, a lady who was referred to me who had been told she definitely needed surgery to manage this infection around her implant. And following the non-surgical debridement phase, we found that there was a foreign body, a particle of food, lodged under the mucosa. And once this was removed, the infection completely resolved and no surgery was required. But this is an illustration of how important it is to do a careful assessment and a non-surgical phase first. Also, in this clinical case, you can see to the far left that the prosthesis is rather over-contoured and it's very difficult for the patient to clean this prosthesis. And hence there is peri-implant infection, the prosthesis is removed, recontoured, and the patient then is able to clean effectively and the infection resolves. So again, a case that really only required adjustment of the prosthesis and a non-surgical phase. In the following case, however, following non-surgical therapy, the infection had not resolved. And during surgery, you can see, if you look carefully to the middle image, that there is some dental floss firmly wrapped around the implant at the neck of the implant. And this has in fact contributed, if not caused, the infection here. So in some instances, it is difficult to make an adequate diagnosis unless a surgical approach is used. So look out for patients who are wrapping floss around implants and the floss is shredding. This could be an additional factor for, as an initiator or a factor resulting in progression of disease. So let's now move on to step number 4, which is surgical treatment. One option is an access flap or open flap debridement. And here the main aim is to get access to the surface of the implant in order to clean it or decontaminate it. So a mucoperiosteal flap is raised. Often these flaps need to be quite large in order to gain access, often with releasing incisions. And then the removal of the inflammatory granulation tissue is performed with curettes. And then comes the step of surface decontamination. And there are many techniques. You saw that from the systematic review we did. Many techniques which can be used and which have been documented in the literature. And these range from various chemicals, gauze soaked in antiseptics or even sterile saline, rubbing the implant surface, hand or powered instruments, various lasers, photodynamic therapy, and in some cases implant surface modification with a burr has been advocated and documented. Now the question I'm always asked is, which is the best treatment? Which is the best decontamination method? And when we look to the literature, we see that there is no clear answer. There is still no one decontamination method which is shown to be superior. In the little video here you see a titanium brush being used on the implant surface with irrigation with sterile saline. So this is one method that can be used. But the extent to which the bacterial and non-bacterial residues need to be removed is not yet known. Of course, if we are trying to regenerate tissue, we would like to remove as much of the bacteria and non-bacterial residues as possible. And there are various new technologies which are underway, but really any of these methods you see on the slide can be used for implant surface decontamination. Now, another type of surgical approach might be the resective approach. This is where there is osseous recontouring, so removal of any bony peaks, and apical positioning of the flap. And this is really done in order to allow the patient good access to oral hygiene at the implants following healing. Now you can see from these clinical slides that the aesthetic outcome is certainly not good after this type of approach. So this is not possible in the anterior region where the patient has a high smile line, and it's also not possible where you have neighbouring teeth where you wouldn't want to lose attachment around those teeth by reducing the bone levels around the implants. This approach often involves the implant surface modification, often termed implantoplasty, in order to try and create a smoother implant surface for maintenance care. So this is the second type of surgical approach that can be used and has been documented in the literature. But now let's move on to the regenerative approach, which, as I explained from our systematic review, many of the studies did attempt to regenerate the bone lost by using various biomaterials and grafts. So here the aim is, after thorough cleaning of the implant surface, to use a bone substitute or bone graft material with or without a barrier membrane, and studies have used both a submerged or a non-submerged healing approach. Now, the literature doesn't show a clear indication of which modality is best. So it depends very much on your preference until we have more evidence in the literature. If you are going to attempt a regenerative approach, then you need a defect with suitable morphology. And to the top right, you can see a radiograph and a clinical intrasurgical photo, whereas there is a crater of bone around the implant. And you can imagine that this is amenable to filling with some type of bone graft material. And in the radiographs below, you see two cases where following flap, implant surface decontamination, bone substitute material has been used together with a membrane to achieve good radiographic bone filling, if you like, and you can see that on these two examples. Now, whether or not this is re-osseointegration, we would only know if we had histology, but certainly this is a good clinical successful outcome with stability for, in these two cases, more than 8 years. And in these particular cases, the BioOS was used together with a collagen membrane, a BioGuide membrane. Here you see one of the cases with the DBB and collagen membrane. You've seen the x-rays in the previous slide. Now you may also note that the crown on this particular implant doesn't look like it fits particularly well. Ideally, it would have been nice to replace this crown, but the patient wasn't prepared to spend the extra money to do that. And in fact, as this is a tissue level implant with the restorative margin well away from the bone, this has been able to be kept clean and the outcome has been very good over a long period of time. Here is another example of the use of deproteinized bovine bone mineral, in this case with the 10% collagen. So this is the BioOS collagen being used, and this has been published in a very recent paper from Mario Rocuzzo, where he also used a connective tissue graft in many of the cases to augment the soft tissue as well. And here the 12-month results showed around 49% of the implants had a successful outcome following this protocol, with a mean reduction in probing depth of 3 millimeters and a mean reduction in bleeding on probing of 70%. But it's also important to note that 6 of the implants in his study had to be removed. So again, the predictability of all of these techniques is not always 100%. So we need to be aware of that when we're discussing the options with our patients. Now, you noted in the Rocuzzo study they used a connective tissue graft to augment or increase the amount of keratinized mucosa. And another option can be to use the collagen matrix, the mucograft from the Geistlich company. This has been documented in numerous studies, and this was one of the first from Sanz et al. In 2009. So there is some evidence that by increasing the amount of keratinized mucosa, the patient will have perhaps a better opportunity to keep things clean, and there will be less inflammation of the soft tissues. And in this study, they did a randomized controlled trial, and they found similar gains in keratinized mucosa, around 2.5 millimeters, when they used the collagen matrix and when they used the connective tissue. Another approach which can be used is to use bioactive agents. In this particular case, Emdogain, or the enamel matrix derivative, was used. And this is just a case report. It's actually a patient where I used the Emdogain in order to try and improve the attachment levels at the neighboring teeth. However, you can see in the radiograph that there has been some radiographic bone fill around this defect of the implant, and there is some evidence, one study in the literature, showing that the use of this bioactive agent can improve the amount of bone fill. So this is something that could also be a possibility for regeneration, and we really do need further studies to show this. Now I'm coming to step 5, which is also a very important step. And this is the immediate postoperative anti-infective protocol. Here we need to follow our surgical procedure with a very close anti-infective regimen, daily chlorhexidine rinsing, and in the studies that I've showed you and that have documented have used 3 to 4 weeks of chlorhexidine rinsing. Peri or postoperative systemic antimicrobials have been used in the majority of studies. And professional support of the healing and plaque control is critical. I'd like to show you a recent study from the Berglund group by Olivier Carquois, published in 2015 in the Journal of Dental Research. And this study highlights a number of things. It shows us that implants with moderately rough surfaces, or they term them modified surfaces, don't do as well following treatment as those with a non-modified surface or a turned surface, such as the old Bronnemark type implants. But this study also showed the importance of the use of antimicrobial systemic antibiotics in conjunction with surgery when you are using an implant with a modified or moderately rough surface. They actually found that there were no implants with a moderately rough surface which had treatment success after 12 months unless they had the antibiotics at the time of surgery. And this particular study is in fact the only randomized control study in the literature comparing antibiotics without antibiotics. They used amoxicillin for a week, and they had a surgical resective protocol for their treatment. So this is really showing us that we don't have a lot of evidence with antibiotics, but we do now know that if you have the moderately rough surfaced implant, you should be using them. And again, you see that their treatment success criteria was shallow probing depth, absence of bleeding and pus, and no additional bone loss. And when they had the non-modified surface, they had 79% of the implants with success compared to only 34% with success at 12 months. Coming now to step 6, this is the ongoing supportive peri-implant therapy. And here what is important to have clinical monitoring on a regular basis, and this is usually between 3 to 6 monthly as reported in the literature. Radiographs should be taken as required. This is your clinical decision that you need to make. And oral hygiene instruction and biofilm removal, both at the implants involved and also the neighbouring teeth, is really important. You need to make sure that there are no periodontal pockets and plaque accumulation around the natural teeth in a partially dentate patient. And I'd like to finish this section by showing you a study that has been recently published, 5-year results. This is the 12-month results of an anti-infective treatment protocol with access flap implant surface decontamination, here using sterile saline and rubbing of the implant surface, a combined antimicrobial treatment for 1 week, followed by chlorhexidine rinsing for 4 weeks, and then 3 monthly maintenance care. And in the following slide, you see the 12-month results with 88% of patients with no disease progression. And in this slide, you see the 5-year results. With this strict peri-implant care therapy, after 5 years, 63% of the patients had a successful outcome. So you can tell your patients that if they follow this protocol, after 5 years, 2/3 of the patients will have a successful outcome according to this paper. Now, we talked at the beginning about when to remove an implant, and this is always something you should at least consider and discuss with the patient. If there is a very severe lesion, if the outcome is likely to be unsatisfactory, perhaps for aesthetic reasons, this should be an option right from the start. When you're removing an implant, you need to pay particular attention to neighbouring structures, get good radiographs to evaluate, and when removing an implant, rather than using a trephine today, we have other devices such as this implant removal device you see in this series of clinical slides, where once the restoration is removed, the device can be inserted into the implant and the implant can be reverse torqued out, having a fairly conservative approach and sometimes allowing replacement with a new implant. In summary, I'd like to show you a series of cases, these non-surgical treated cases with systemic antimicrobials or antiseptics with a successful outcome after 5 years, a surgical approach, resective, regenerative, and another regenerative case, and finally some cases where the implant could not be kept, where it was removed. And the decisions that we need to make are influenced by this list of factors on this slide: severity of the lesion, the access for the therapy and the maintenance care following. The defect morphology may influence our decision as to whether to try a regenerative approach or not. The position of the implants, the proximity to neighbouring teeth, the number of implants. Sometimes we can remove an affected implant because we have enough other implants to support the prosthesis. So we need to consider the strategic importance of the implant. we should always consider the patient's expectations, discuss with them the possible adverse effects, and of course the costs involved, because ultimately they will have to make the decision. And I think you will agree with me that the patients are going to ask you, or they ask us every day, how long will this treatment last? They don't care how many millimeters of probing depth reduction they'll have, or how many sites even will still be bleeding on probing. What they want to know is how long will their implant last, what will the treatment cost, what is involved, and how often will they need to come back for maintenance care. So these are the things that we need to discuss with them, and I really hope this six-step protocol has given you some insight into how to make your decisions in everyday practice. Now here in this slide you can see where I'm sitting at the moment at our practice in West Leederville in Perth, Australia, and in the top right is my office, and I'm sitting here waiting for your questions. And now I have my assistant, Angela, who's going to show me the questions, and I'll do my best to answer them for you. So the first question is augmentation a risk factor for peri-implantitis? Meaning, are implants in augmented bone more likely to develop peri-implantitis, or does it lead to faster progression of peri-implantitis? Now this is a really good question, and the fact is I can't give you a clear answer. We do not have the literature today to give us a clear answer to this question. I think if augmentation is done well, and if a patient has everything else done well, including a good reconstruction, has regular maintenance care, I can't see that there would necessarily be an increased risk for peri-implantitis. But there were many steps involved in my answer. Everything has to be done very carefully. I'm going to go back to question 2, and that is for the regenerative approach of peri-implantitis treatment, are there any differences in the performance of different graft materials? Again, there is limited literature to compare, to have a good overview of all of the different graft materials, but there are studies which document some graft materials very well and others where there is limited documentation. So my answer to that question would be to use biomaterials that have been well documented. And for example, the Geistlich materials have been well documented in controlled trials, looking at, for example, BioOS with or without membrane. Whilst they may not give a clear answer to which is the best approach, we can clearly see well documented studies with up to 4 years or longer outcome. So I think it's really important, whatever you're going to use, to make sure that they have been documented well, rather than use something that has no studies or very few studies. And that is my approach when I'm treating patients. Question 3 was, does the implant surface of different implant brands make a difference in Redguards to the susceptibility of peri-implantitis? Now, there are some studies showing that very rough surfaces, such as the TPS surface, patients with these implants will have more peri-implantitis. And there is a recent study from Sweden which shows that certain implant brands have an association with peri-implantitis. But we have to be careful looking at that evidence and saying that it's definitely the implant surface. There may be other factors as well. What we do know is that, and I alluded to this in my presentation, that certain implant surfaces are more difficult to treat. So the moderately rough surfaces are more difficult to treat than the smoother turn surface implants. So in that respect, there is a difference. But in terms of the the Swedish study where they showed some implant brands have a higher association to peri-implantitis. There are other factors involved there, such as the implant design. And in that particular study, they showed that the tissue-level design implant, patients with these design implants as opposed to the bone-level type implant, had less peri-implantitis. And I would speculate that that is because the restorative margin is further away from the bone crest. So it's not as simple as the implant surface. There are many other factors involved as well. Question number 4. In which situations would you consider an implant surface modification, smoothening of the implant surface? So that is what I termed implantoplasty before. And in my practice, based on the literature, I don't actually do that. But when might I consider it? Possibly when I had treated peri-implantitis, I had had good healing, and there were then numerous threads supramucosally, so exposed in the oral cavity. I might then consider removing those threads with a burr in order to make it easier for the patient to keep it clean. There are some good studies in the literature using this approach in combination with regenerative treatment, use of biomaterials such as the BioOS material. Good. So we're coming to question 5, and that is, what can you say about the long-term prognosis of an implant that has undergone peri-implantitis treatment with regenerative approaches? Right. Well, with regenerative approaches, the long-term outcomes, there are a few studies which have shown favorable outcomes with, the majority of patients and majority of implants with success after periods of up to 7 years. But these are very few, these studies. So we really need more long-term studies. And we really need to know what has been done in the supportive peri-implant therapy stage. The rationale for regenerating is to help stabilize the tissues, to enable the patient to have good access for oral hygiene and to maintain a healthy situation. So I would say if a patient has a successful outcome after 12 months following a regenerative approach, if they are then in a good supportive therapy program, they have a good chance for long-term success. So I'd like to finish there and thank you all for joining me, and thank you Geistlich for inviting me to participate in this webinar. Good night.